People think a sir is not able to join funds.
So, good evening, friends. We have the honor of having very eminent faculty today. Professor Saravanan sir, Professor and Head of the Department, Madurai Medical College. We have Professor Gupta sir joining shortly. Gupta sir, are you with us, sir? He is from Hind Institute of Medical Sciences, Sitapur. And we have our own faculty, Professor Jailal sir, joining from Guwahati. And today we have a postgraduate, Dr. Monisha, who has already been with us some time back, kindly contributed by Professor Amit Gupta from All India Institute, Rishikesh. So, friends, as we have exams, we are closely concentrating on the standard exam cases as a long case model. And now that the NMC has also changed the pattern, we will also look into that type of conducting the exams. So we have Dr. Monisha presenting today. Dr. Amit, good evening, sir. So Dr. Monisha will be presenting a case on obstructive jaundice. Monisha, please introduce yourself, your unit
Good evening,
chief.
Dr. Kagnavil.
Good
Yes,
evening,
sir.
sir. Thank you for joining today, sir.
Yeah, how are you?
Sir, all good, sir. All good, sir. And thank you for permitting your student to present the case today, sir.
No, sir. It's an honor.
Thank you,
I
sir.
think
Thank
can
you, sir.
start?
Yes, sir. Yes, sir. We are just about to start, sir. Monisha, you please
Good evening.
introduce yourself.
Yes, sir.
Please switch on your video. Yeah, good. So please introduce yourself, your unit chief, head of the
Yes, sir.
department, and start your presentation. Good luck to you, ma'am.
Yes, sir. Yes, sir. Thank you, sir. Good evening, respected faculties. Myself, Dr. Monisha, second year junior resident from Department of Surgery from All India Institute Medical Sciences, Rishikesh. My moderator is and my guide is Professor Amit Gupta, sir, from Department of Surgery. Our head of department is Professor Somprakash Basu, sir. Shall I start, sir?
Yes.
Um,
Are you okay, ma'am? Please start.
sir, I have opened some other.
No, your PowerPoint was seen, right?
Sir, that is other one, sir. My final one I will open, sir, shortly.
Okay. Please go ahead.
Yeah, Dr. Kagnavil.
Sir, yes, sir. Good evening, sir. Tell me, sir.
Yeah, are you coming to Agra, Asikon?
Sir, I'm making it, sir. I'll be there on 12th and 13th, sir.
1200. Okay, so I will be there also. So just call me. We will meet, sir.
100%, sir. 100%, sir. We'll make it,
Sure.
sir. We'll make it. Is this the right one, Dr. Monisha? The
Yes, sir.
corrected one?
Yes, sir.
Okay, ma. Make it full screen.
A gentleman, aged 46 years, resident of Bijnor, Uttar Pradesh, former by occupation, presented to surgery OPD on 22nd November 2024 with chief complaints of yellowish discoloration of eyes and skin for 1 month, passage of high-colored urine and clay-colored stools for 1 month, itching over the trunk and extremities for last 20 days. History of presenting illness. The patient presented with yellowish discoloration of eyes and skin for 1 month, which is noticed by family members, which is progressive in pattern, associated with high-colored urine for 1 month, passage of pale-colored stools, itching over the trunk and extremities for the last 20 days. There is also a history of loss of appetite and unintentional, undocumented weight loss in the last 1 month, which is noticed as loosening of clothes. There were no history of abdominal pain, vomiting, abdominal distension, black tarry stools, bleeding per rectum, fever, malaise, bone pain, hemoptysis, breathlessness, headache, visual disturbances, backache, tattooing, blood transfusions in the past. There are no history of tuberculosis, diabetes mellitus, asthma, hypo or hypothyroidism, hypertension, ischemic heart diseases. There are no history of previous hospitalization. There are no history of any surgeries in the past. He's married, having 2 children. His sleep is disturbed due to generalized itching disorder. Patient is vegetarian by diet. Patient has a history of alcohol intake since 20 years, 250 ml per day. He has a history of smoking, 18 pack years, 18 pack years. Family history. There is no history of similar disease in the family. There are no history of any malignancy and malignancy related deaths in the family members. Summarizing the history, a gentleman aged 56 years, chronic smoker and alcoholic, presented with painless progressive jaundice and passage of high colored urine and clay colored stools for 1 month, which associated with itching over the trunk and extremities, associated with loss of appetite and loss of weight, with no prodromal symptoms and no known comorbidities.
So, Monica, can we go to the first slide so that we can go slide by slide?
Yes, sir.
Quickly, finish the summary. Okay. Gentleman, 40 years old. What is the age? The jaundice.
46 years.
46 years. What etiology and age group?
Sorry, sir.
Etiology for jaundice in this age group. Commonly. Etiology.
Yes, sir. Sir, it could be both benign and malignant, sir, in this age group.
Okay. First of all, what is jaundice? Is it a disease or anything else?
Sir, it is a manifestation, sir. It is a yellowish discoloration of skin and eyes, sir.
Basic also, you must refresh so that first years may watch. That's why I'm asking these basic questions. Okay.
Yes, sir.
First of all, a symptom. Okay.
Yes,
So
sir.
system you will consider to be affected.
Sir,
System.
hepatopancreatic biliary systems.
Okay. In jaundice, hepatobiliary system, what are major types of division that can cause jaundice? Major
Sir,
division.
it could be medical jaundice, sir. It could be surgical jaundice, sir.
Okay. Okay. What are the manifestation of medical jaundice likely to be? Initially, what will be the symptom? Later on, what will be the symptom in medical jaundice? Similarly, in surgical jaundice.
Sir, in medical jaundice, jaundice will be preceded by prodromal symptoms, sir, like fever, malaise, arthralgia, myalgia, sir.
One more thing you left over. Important thing. Everything told. Vomiting also. Nausea and
Yes, sir, vomiting, nausea, vomiting. Yes, sir.
vomiting. Whereas
Yes, sir.
in surgical jaundice,
Sir, jaundice. Yes, sir. Jaundice, high colored urine, pale colored stools associated with itching, sir.
okay. What happened to vomiting in surgical jaundice?
Sir,
Whether it
vomiting,
happens early or late?
late stage, in advanced cases, sir.
Advanced stage only. Okay.
Yes.
Okay. What is the minimum bilirubin level required to produce clinical manifestation? What is the
Sir,
cutoff?
2.5 to 3, sir. 2.5.
Okay. Which area is first initially seen? Jaundice.
Sir, patient notices over eyes, sir, in sclera, sir.
Sclera. Why?
Sir, due to high elastin content, sir. Bilirubin has a high affinity towards elastin, sir, and decreased melatonin.
Okay, elastin is there everywhere, ma. Everywhere,
Yes,
not
sir.
only in
Sir,
the.
absent melanin.
So that is the main reason. But elastin
Yes,
will be there. The affinity will be there for elastin. Okay.
Yes, sir.
But what is your age of the patient?
Sir, 46 years.
See your summary. Go to the.
Sorry, sir.
Yeah.
It's 46 years.
No, there are a lot of inconsistencies there. In somewhere, it's a real case, no? You have seen the case.
Yes, sir.
Okay, because the originally what you have sent 3 years, 3 months. Now it is 2 months, 1 month. Okay, but this is the final. What is your statement?
So this is the final.
Final, but again there is a year waste is there. So that should not be there in the examination.
Yes, sir.
I think that should be very careful. Okay, go ahead, sir. Please go ahead, sir.
Yes, sir. Is it high colored urine or colored urine? What is the difference between high colored urine and the colored urine?
Sir, discoloration of urine could be because of jaundice, sir.
What is the normal color of urine?
So straw color.
Straw color. High colored means what? It can be a concentrated urine, right?
Yes, sir. Yes, sir.
Is it concentrated or do you think at this stage? Because it's only a history. So we cannot conclude.
Yes,
okay. It's a
yes, sir.
Okay. Okay. Itching trunk and extremities means what? The whole body, you can say. Itching
yes,
all over the Itching all over the body, because it includes all the things in the part of the body except the head and neck. Okay.
Yes, sir. Yes, sir.
So say itching all over the body.
Yes, sir.
Okay. Loss
Now,
of
doctor,
appetite.
please tell me that all things according to you start with the 1 month. Is that is a big deadline or like a storytelling? You are saying that everything eyes problem started at the 1 month, yellowish discoloration started on the first 1 month, and loss of appetite and lots of things started with the 1 month. How do you come to that arbitrarily on a one fine morning? All these problems started.
Sir, yellowish discoloration was initially noticed by family members, sir.
He's a 46-year-old member. Man, so then again, that was 1 month.
Yes,
Again, your appetite, loss of appetite is also 1 month.
sir. Yes, sir.
So in this process of jaundice, and what would be the first symptoms to occur?
Sorry, sir. What will be the
First manifestation, or what is the clinically, which one will manifest first? You have now put everything in the 1 month duration.
Yes, sir.
So I mean, we are not able to convince, we are not convinced on that, including loss of appetite and everything starting on a particular day. So if at all the first symptoms or first sign, what they will notice? Is it an eye sign or a discoloration of the urine?
Sir, urine, sir.
What? Urine. So that you know now, hyperbilirubinemia and jaundice. Hyperbilirubinemia can manifest with the urine color will be increased. Only when
Yes,
it
sir.
goes beyond 2.5, you get other symptoms.
Yes,
But
sir.
here, all at least you say that they noticed or something like that. Not that you cannot say illness discoloration eyes since 1 month. Patient has noticed. You can say that way you can escape. Not statistically saying that it is a 1 month for passage high colored urine for 1 month. That is your observation, your finding. That will not be. Can you get a jaundice without high colored urine?
Sir, acholic jaundice, sir.
What is the mechanism?
Sir, in hemolytic disorders, sir, the rapid degeneration of RBC, sir, which are causing rise
No,
in.
I'm not asking the etiology. What is the mechanism? It is acholoric.
Yes,
Why
sir.
it
So
is
that is
acholoric?
unconjugated bilirubin is rise. Indirect bilirubin is raised, sir,
So what?
which is not water soluble, sir. So it will not be excreted in the urine, sir.
Okay. You have put that roti is something loss of appetite or early satiety. Which one is correct here?
So reduced appetite, sir.
How do you know? Come to conclusion. This appetite is reduced. What is the criteria
according to
used to say?
So in early
How
satiety, the patient will be having preserved appetite, sir, but the patient will not be able to take more, sir.
Okay, what is happening in this patient?
So the patient is having reduced appetite, sir.
No, how it manifests? Reduced appetite means how do you understand that it is a reduced appetite?
So decreased desire to food, sir.
Any reason for that? Like desire for the food?
Yes, sir, because of interleukin 6, sir.
So here that patient is not able to take food.
Yes, sir. He's having a decreased appetite.
Okay, you are talking with the liver, obstructive jaundice, and why it produces interleukin 6 and all? What is the reason we are saying?
Sir, jaundice per se also will cause a decreased appetite, sir.
That is hepatic jaundice.
Yes, sir.
Okay. So you mean to say this is hepatic jaundice?
No, sir.
Okay. You are sure you have passed the history properly and say that it is a loss of appetite, not early satiety?
No, sir. It's
Okay.
decreased appetite, sir.
Okay. Okay.
Second slide. Yes. Why you asked all these questions? Can you elaborate? Abdominal
Yes, sir.
pain, what is the significance? Suppose the patient is having upper abdominal pain. right-sided especially, what do you think of?
Sir, pain will be in advanced cases of pancreatic malignancy, sir.
Why
But
you are
it can be
always
in the,
thinking of malignancy only in this patient?
sir,
So,
it could be, so
uh,
pain could be in cholecystectomy also, sir, but it will be acute episode, sir. So
okay.
pain, jaundice, fever, patient will present in cholangitis, sir.
Not
It is
necessarily.
progressive jaundice.
No,
Yes, sir.
all patient with obstructive jaundice will not, with a gallbladder stone or the CBD stone will present with the cholangitis. And what percentage of pancreatic carcinoma will have pain?
So 60%, sir.
Not even 60. Then that only have the pain. So you want to put everything to the malignancy and trying to bring in. So will the pancreatic malignancy will produce vomiting?
Sir, in advanced cases, sir. If it infiltrates duodenum and causing obstructions.
No, no. You are expecting how the pancreatic malignancy cause obstructive jaundice?
The compression of, if the pancreatic cancer arises from the head of the pancreas, sir, it compresses common bile ducts.
No, you cannot compress common bile duct without compressing the CBD. Sorry, duodenum. So when
Yes,
it is
sir.
compressing, you are expecting the CBD to be compressed. That
Yes,
means simultaneously you will have some compression effect on the duodenum and patient will have a vomiting.
yes, sir.
If there is any other way?
So causing mouse effect on the stomach also, patient can has vomiting, sir.
No, you are talking about jaundice.
Sir, periampullary carcinoma, sir, obstructing common bile duct can cause.
So you are thinking in terms of periampullary carcinoma here. Okay,
Yes,
fine, go ahead. We will come to that explanation.
Monisha, also you must notify whether it's a progressive jaundice or intermittent jaundice or waxing and waning type of jaundice. What is the significance of these three types of jaundice?
Sir,
Progressive
so waxing waning type will be seen in periampullary carcinoma or any papillary variant of cholangiocarcinoma, sir.
Okay.
So where tumor outgrows its blood supply and slumps off, sir. It causes
Waxing and waning of what?
jaundice, sir.
That is bilirubin level.
Yes, sir.
No. It takes long
So the
time. What
patient
is
will be symptomatically better, sir. Appetite will be
no,
improved.
it is you are going to only look at the symptom of that.
Yes, sir.
The biochemical value of bilirubin will not. Why it will be taking long time?
Sir,
What is the
half-life of
half-life
bilirubin is long, sir. 21 days, sir.
So you will not get it immediately, the change in the bilirubin level. So it is only the symptomatic waxing and waning. And how much time? Your total history is only 1 month. Do
Yes,
you
sir.
expect the waxing and waning can come
No,
there?
sir. No, sir.
But
Sir, in
you said
intermittent,
abdominal pain, it is radiating to the back. That is what you said, no?
sir, my patient is not having abdominal pain, sir.
So it is a painless jaundice.
Yes, sir. Painless progressive jaundice.
Okay.
History of tattooing and blood transfusions should not come in present illness. Okay.
Yes, sir.
What is the significance of tattooing here? Jaundice.
So tattooing any transmission of hepatitis C, hepatitis B, sir. That
Okay.
might cause jaundice.
That will take some time, but will not be within the present illness during
Yes, sir.
the course of illness. Okay. It will be a past
Yes, sir.
history. Similarly,
Yes, sir.
the blood transfusion also, except for hemolytic jaundice, right?
Yes, sir.
So you must evaluate whether it is a jaundice due to stones or malignancy, painful jaundice or painless jaundice. As sir said, if it is chronic duration, it's a progressive or waxing and waning or intermittent type of jaundice, that also should be included in the history. Or you can say, since it's 1 month duration,
Yes, sir.
that history that has to be asked, but it is not relevant in this patient. Right? That you have to say that is a very important point related to
Yes,
the
sir.
obstructive jaundice. So medical jaundice,
Yes.
we can not bother about these things. Even medical jaundice, will it cause obstructive type of jaundice, surgical type of jaundice? In medical jaundice, hepatitis,
Sir,
will it
in
cause?
cholestatic phase of medical
In
jaundice, sir.
cholestatic phase, it may cause pale stools also. Okay.
Yes, sir.
Okay. Go to the next slide.
What do you expect the black tarry stools? And in this case, you are putting as no black tarry stool.
Yes, sir.
Why?
Sir, in periampullary carcinoma, sir, or a papillary variant of cholangiocarcinoma, if the tumor slips off,
What do you get?
sir, when the tumor outgrows blood supply necrosis, sir, that
Usually you
produces
get a, is there anything more specific? In a periampullary carcinoma, what type of bleeding will be there?
so silver colored stones.
Okay, you are not mentioned that. If you are thought that it is an periampullary carcinoma, here you have mentioned only is a black tarry stones.
Yes, sir.
So why you are expecting that? So what is the cause for that black tarry stone?
The bleeding, sir, bleeding into,
The bleeding from where?
sir, if it is duodenal carcinoma or if it is periampullary or even cholangiocarcinoma, also papillary variant can
So
cause this,
suppose
sir.
if it is bleeding from the small bowel, if
Yes,
it is
sir.
bleeding from the ascending colon, will you get a black tarry stool?
Yes, sir.
Okay. What is the mechanism there?
So gut bacteria does
So there is
oxidative
a
reaction.
difference in the melena from the upper GA and the lower GA. Upper
Yes,
GA
sir.
is acid rheumatin. Here
Yes,
you
sir.
are going to get a. So what is the relation of this gallbladder and this stone or the CBD which you are thinking with the small bowel? Is anything prone for that? Any relation of obstructive jaundice, and what is the effect it is on the colon?
Sir, intestinal obstruction because of gallstone ileus can happen, sir.
That is very, very rare. Mechanism, physiological mechanism. When there is obstructive jaundice, what changes will take place in the
Sir,
lower ileum?
intrahepatic circulation will be altered, sir.
So what are the
Gut
effects?
pathogens will be altered, sir.
So what will happen? What deficiency will happen and why it is happening?
Yes, sir. Absorption of fat soluble vitamins and lipids will be affected, sir.
Oh.
Patient
So
will be having manifestation of deficiency.
Why in neonates you are going to give vitamin K when the baby is born? Sometimes we are giving the supplementation of vitamin K. What is the mechanism?
So neonate will be deficient of vitamin K, sir. From mother to neonate, it will not transfer.
So vitamin K is not a transferable one, it is synthesized in the liver. Vitamin C, K, and albumin are only endogenous synthesis. Liver has to synthesize.
Yes, sir.
The same mechanism, as you said, here the bacterial action is damaged. In a neonate, bacteria will not be formed. The
Yes, sir.
deconjugation will not take place. So that is what is playing a major role.
Yes,
Any other lesions can comes in the bowel. Only is the vitamin K absorption. Is it prone for anything more? There's a big study is going on, no? Cholecystectomy leading to
colorectal carcinoma.
colorectal carcinoma.
Colon carcinoma. Yes, sir.
Okay, go ahead.
Yes, next slide. Say past history is more relevant, should be very, very relevant. Okay. You have vaguely
Yes, sir.
asked all these questions. So regarding drugs, what are the drugs you have to ask for? You have to ask for hepatotoxic drugs, hepatotoxic agents, cholestatic agents. Okay.
Yes, sir.
Can you tell some hepatotoxic drugs or agents and cholestatic agents or drugs?
Sir, rifampicin, valproate,
Okay, antituberculous drugs then.
valproate, sir.
Okay.
So sometimes fluconazole.
Okay.
So methyl dopa.
Okay.
So OCP also can cause cholestatic picture, sir.
Cholestatic type of chlorpromazine also. Okay.
Yes.
Okay, halothane agent. Okay. Halothane.
Sorry, sir.
Halothane. Hepatotoxic.
Halothane. Yes, sir. Yes, sir.
Halothane. Okay.
Yes.
Similarly, surgery also should be specific. No history of any surgery in the past. That is vague. Okay.
Per abdominal, yes, sir.
Per abdominal what?
So cholecystectomy would be more specific, sir.
No, any upper abdominal surgery.
Yes, sir.
Or hepatobiliary surgery, upper abdominal surgery. Like that, you have to mention it. In spite
Yes,
of
sir.
it. Okay.
Yes, sir.
Any other things that transfusion history you have to bring into the past history.
Past
The
history.
tattooing
Yes, sir.
history. Okay.
Yes, sir.
Any previous history of treatment for cirrhosis also.
Yes, sir.
You have mentioned tuberculosis, diabetes, asthma, everything. Why cirrhosis is important? or previous history of viral infections. Okay, what type of viral infections?
Sir, hepatitis
Ah.
B,
Specific.
C, sir.
B and
Even
C.
HIV can cause cholangiopathy, sir. AIDS cholangiopathy can cause.
Okay, why cirrhosis is important in the history, past history? In terms
Sir,
of
cirrhosis
malignancy of
could,
hepatobiliary, in terms of hepatobiliary malignancy, why cirrhosis is important?
sir, hepatocellular carcinoma, sir.
Yes, yes. Okay, so be specific in collecting the past histories, right?
Yes, sir.
Okay, next slide.
You are thinking in terms of by history. What is your provisional diagnosis? You are thinking.
Sir, by history, carcinoma head of pancreas, sir.
How?
Sir, he's smoker, sir. Smoker and chronic alcoholic, sir. And painless progressive jaundice, sir.
You have thought it is a obstructive jaundice. No.
Yes, sir.
So first possibility you are thinking is a pancreatic carcinoma. Any evidence for you? But one is the history you are saying, but no vomiting, no pain. Pancreatic carcinoma, 25 to 30% will have a pain. Pancreatic carcinoma can have a diabetes. So
Yes,
no
sir.
other symptoms is related to pancreatic carcinoma is there.
So I would like to think, sir. He's a smoker, sir. Significant accuracy he's having. So smoking is a risk factor for
So many things.
the pancreas. Yes, sir.
Smoking is a risk factor for everything in the body. Okay, you can go for the investigations and find out. But how do you come to a conclusion that when the history itself that is at the pancreatic head of the carcinoma, we are not sure.
So it would
Keep
be head of
always your
pancreas. Yes. A differential
keep your
diagnosis
things
would be
open. Yeah.
periampullary distal cholangiocarcinoma.
Distal cholangiocarcinoma. So why you are ruling out hepatocellular carcinoma? Why not it is hepatocellular carcinoma? Okay, go ahead.
So jaundice preceded loss of appetite and weight, sir. In
Jaundice?
hepatocellular carcinoma, lump, loss of appetite,
Hmm.
loss of weight will be predominantly seen, sir, rather than jaundice, sir.
Okay. Here you think it is a secondary carcinoma. So the pancreatic lump will not be seen first, or pancreatic problems will not be seen first before jaundice is developing. It is not jaundice is developing first, like a hepatocellular carcinoma. Here, some other carcinoma is coming, and you said that is the reason. Okay, go for the next.
Why do you think
Sleep
sleep is disturbed? What do you think it may be due to? Sleep is disturbed due to generalized itching. Any other cause of sleep disturbance in this patient?
Sir, if the patient is having hepatic encephalopathy, he will be having more sleep, sir. Sleep pattern will be disturbed, sir.
Okay.
What do you mean sleep pattern?
So sleep pattern.
Sleep cycle will be altered, not the sleep pattern. Sleep pattern is the REM sleep and
REM
non-REM.
and the NREM's pattern. Yes.
So, is there will be any change that will be happening with that?
No, sir.
Is a patient with the hepatocellular hepatic encephalopathy, he will have a daytime sleep will be there, and it is a cycle. And with the cycle, there will be a change,
Yes,
but
sir.
not the typical when you say use the word pattern is there. Here you are saying the sleep is disturbed due to generalized itching for 1
Yes,
month.
sir.
Okay. So there is no itching in the daytime.
So patient is having itching daytime also, sir.
Okay. You had okay, come to the general examination, we'll see if there is a scratch marks are there. Okay. So why do you think alcohol and smoking, you said smoking causes pancreatic carcinoma, what is the mechanism?
So smoking is a risk factors for pancreatic malignancy, sir.
Is it enough your PG says that it is a risk factor? How it is produced a risk factor? Which component of that is causing a expected? What is the role of nitrosamine compounds? And how the alcohol is it a compound? It's a compounding or it is added when the smoking and alcohol is added? What is going to happen?
Sir, in pancreatic malignancy, it is compounding, sir. It is additive to smoking, sir.
So in their pathogenesis, you should read.
Yes, sir.
Okay.
Also, in the family history writing, you have to be specific also. Any malignancy, malignant related death. It is not necessarily to be death occur in the case of all patients, relatives, okay, due to malignancy, right?
Yes, sir. Yes, sir.
You can colorectal malignancy, pancreatic malignancy, or ovarian malignancy, like that.
Breast and ovarian malignancy.
Yes, like that.
What do you mean by similar disease in family? No history of similar disease in family.
So jaundice in family members.
So nowhere in the family member had a jaundice. When the childhood
No, sir.
jaundice, infantry jaundice. So that is only your only problem I want to say. No jaundice in the family. As far as possible, avoid the term similar disease.
Yes, sir.
Similar disease is the same type of disease which you have described occurring in a person. So that is why at the end of the provisional history, present history, you are going to make a system which is involved. You may say that there is no disease pertaining to hepatobiliary system or whatever that manifestation. Because you are confident at the end of the history taking, you are going to see that what is the problem system, this patient, you are now concluded. That is what you need to bring in.
Yes, sir.
Like Sarah said, don't put a vague terms, especially for postgraduate. Don't use the word similar disease, nothing relevant. All this should be avoided. And any malignancy, mean what malignancy you look for, ask for in the family.
Breast and ovarian malignancy, sir.
Only that.
So colorectal malignancy, sir.
So it will go on, but then how can we rule out any malignancy in the family? You have only 30 minutes time we are going to give in the examination.
Yes, sir.
30 to 45 minutes. Can you ask all the history? Don't but make a blanket statement.
Yes, sir.
So you can ask one or two questions to him, specific questions, and with that they are answering that. Now you are giving a very blanket statement for the entire family. That is nothing have a problem with that malignancy. That should be avoided. Okay.
Yes, sir.
Good. Go
Shall I proceed with examination, sir?
ahead.
Yes.
On general
What is
physical
that?
examination.
Go ahead.
On general physical examination, the patient is conscious, oriented to time, place, person. The patient is averagely built and nourished. The patient is well hydrated with a BMI of 22.67 kilogram per meter square. The ECOG score of 1 and KPA score of 90.
Just a minute. Well hydrated, don't mention it, okay? If it is dehydrated, you can mention it, or hydration adequate, okay?
Yes, sir.
You are well hydrated patient in a jaundiced, deeply jaundiced patient, right?
So after resuscitation.
After resuscitation, okay, maybe, but it may not be always. Okay.
Yes, sir.
In fact, he may go for dehydration. Okay, fine. Next slide.
Hydration is adequate is a better word. And
Yes,
what
sir.
is that average built and nourished? How did you assess? What is built?
So build refers to the skeletal framework of a patient, sir.
What is that
Nourishment.
average? What is that average means? We have only
So objective score of BMI 20.
BMI. So somebody who has 100 kg weight is a well-built individual. That is your term. And how do you come to the nourishment here? What are the factors you looked for saying this patient is nourished? You said the patient has a loss of appetite, loss of weight, is a loosening of the shed, weight loss is there, and
Sir,
he's
on
a chronic
temporal hollow.
Alcoholic for 25 years and a smoker. So for that patient, you say he is well nourished. And what are the nourishment abnormality you looked?
Sir, temporal hollow means a sunken eyes.
Sunken eyes for okay, periorbital fat, pulp face. That is for anemia you are going to look, or the loss of fat. It's not only the fat, it's only the nourishment. What is up with the protein?
Muscle
Is he
mass,
having
yes, sir.
He's having a sarcopenia. He's having any other vitamin deficiency. So with a hepatic problem, you talked about bleeding in the earlier, and other vitamins also can have a problems. Vitamin A deficiency can cause problem. Have you looked all those things, and have you checked for the muscle arm, mid-arm circumference?
No, sir. Mid-arm circumference, I haven't checked.
Because this is one of the case where we are malignant case, which we are especially in the surgery, we are going to see, and we need to look for any cutaneous malignancy signs. No, you are giving a very blanket statement again. He is an average built and nourished. He is
Yes, sir.
average built because he has come to the hospital. His build is normal, adequate. What is the problem
Yes,
in his build? Only the nourishment we have to check. You check all the point in favor of nourishment and to come to say.
Okay, sir.
Okay.
One more point, Monisha.
Oh,
You have to mention the general examination signs of acute liver cell failure or chronic liver cell failure, right? Just like that, you can mention, and the examiner asks, you can mention what are the signs of chronic liver cell failure. General examination, what are signs of acute liver cell failure in the general examination? As sir told, 1 or 2 points. Cutaneous manifestations. You must be
I
able
have
to
put,
tell.
sir.
Okay, okay.
what is your BMI?
Sir, patient BMI, sir.
Yeah.
22.67, sir.
What is the kg per meter square?
So unit.
Okay. BMI has a unit. Who has given that
Yes.
unit to BMI? BMI, anybody has given a unit, no? It is a formula. Kg
Okay, sir.
per meter square is a formula which you are used. When
Okay,
somebody
sir.
asks you the value of blood urea, you will not put the value of a formula which you are used.
Yes, sir.
So BMI is a number. It is only a number. That kg per meter square is not what we are supposed to use. So in which
Yes, sir.
condition, which case you are permitted to use a kg per meter square? In a therapeutic drugs, anti-cancerous drugs, when you are giving, you will write that is a, what is the dose of 5-fluorouracil?
I'm not aware, sir.
Okay. It will be always mentioned as a kg per meter square. That meter square denotes surface area.
Okay, sir.
You know what is the normal
Sir,
surface area?
can I interrupt here? Can I
So
interrupt?
1.73.
1.73. Okay.
Yeah, actually, whenever a case is being presented and there's a slight suspicion of malignant etiology in candidate's mind, so saying BMI in kilogram per meter square is always advisable, and it is well explained by the fact that any intervention, whether in form of surgery or in form of chemotherapy or whatever, immunotherapy or radiotherapy, that might lead to change or the disease also progresses. So
No,
you
sir, how
that
it what my point is, kg per meter square is not the unit. Kg per meter square is a formula by which we are finding out the BMI. The BMI only he has to say 22.67. There is no point to put it is a kg per meter square. Then if you say that meter square, then somebody who has is it going to be decided by this individual is 50 kg, then meter square is some 60. So is it going to be multiplied or not? So ideally it should be BMI should be mentioned. It is definitely you need to mention, but don't use the word kg per meter square.
okay.
sir.
Go ahead, Monisha.
The patient is afebile on touch. Pulse rate is 63 beats per minute. Regular good volume. BP 120/80 millimeter of mercury in supine position measured in right arm. Respiratory rate 18 breaths per minute. Saturation 98% on Romer. Patient is ectic. There is no clubbing, cyanosis, edema, peripheral lymphadenopathy noted. Scratch marks present all over the body. There are no signs of chronic liver disease present. Systemic examination where
Are you anything significant you have seen there? What is the pulse rate? Is 63? Is it significant?
also relative bradycardia, sir. Towards
Relative bradycardia. What do you mean the word relative bradycardia?
so not relative brady. So
No,
it
there is
is
no word called
slightly on the
relative
lower side of the normal range, sir.
Okay, it is bradycardia. Relative bradycardia is a different meaning. Okay,
Yes,
we
sir.
have in in a typhoid fever, Hendrix fever you
Typhoid.
have. Yeah.
Yes.
Here it is not that relative bradycardia, because that is even when the temperature is raised, comparatively
Heart rate
the
is not
pulse rate
raised.
is not raised. That is what the relative bradycardia. Here the bradycardia. So
Yes,
why
sir.
there is bradycardia?
So the bile cell deposition in the SA node and AV node, sir, or it can stimulate vagotonic effect also, sir. Sometimes it may lead to release of MDF factor also, sir. Myocardial depressant factor also, sir. All
Very
these things
good.
can lead to bradycardia, sir.
Okay.
Mr. Monisha, afebrile
Yes.
on touch, don't mention like this. Patient is afebrile, that's all.
Okay,
Febrile
sir.
illness manifests in so many ways. Patient will be in a rigor state. There are so many things we can measure it like that. To say
Okay, sir.
afebrile or febrile condition, must not only by touch we can measure it. There are so many methods also. So don't mention on touch. Okay. Go to next
Yes,
slide.
sir.
Okay.
So you are very sure the patient is not cyanotic. I mean, there is no clubbing in his hand.
No,
You have
sir.
a really, please, because be careful, especially when a patient who has a 25 years of smoking. One of the commonest manifestation is they will have the clubbing.
Clubbing, yes, sir.
So many times we have seen examination, the students coming and saying, not giving much importance to that and say there is no clubbing, when obviously when the examiners look, there will be clubbing. So, I mean, I'm not saying finding fault with you, but please be careful,
Yes, sir.
especially
Yes, sir.
people like this and with a liver problem or with a chronic respiratory, I mean, smoking. You must
Yes,
look
sir.
for that.
Yes, sir.
So,
Okay, sir. So systemic examination was unremarkable. CNS, no focal neurological deficits, sir. Respiratory bilateral air entry present.
what are the focal neurological deficit you looked for?
Sir, hemiparesis, paraparesis.
They are not focal. They are obvious.
Weakness.
They are major. So you can only say no obvious neurological deficit or the major neurological deficit, because within a limited time you will not be able to check all the small things. Because your case, you are suspecting pancreatic malignancy, no pain you are seeing. So there are many things you need to do, whether there is a pain is there and whether there is a pain in checking. A lot of examination has to be done. So here you can say the no obvious neurological finding and reflexes intact, power 555. I don't think it is necessary for you to put all these things in an examination.
Yes, sir.
The examination, we are expecting you within 40 minutes what the major things you can do and something which is related to the case which you are presenting.
Yes, sir.
You are looking for your power 555 in all four limbs will take much of your time.
Yes,
The
sir.
genuinity of your examination is more important than reporting all that is what is given in the textbook.
Yes, sir.
Okay, good.
So coming to peritoneal examination, on inspection, the abdomen is not distended. Umbilicus is inverted and present in the midline. All quadrants of the abdomen moving proportionately with respiration. There is a visible fullness noted over the right hypochondrium. The lowest discoloration of skin and scratch marks noted all over the abdomen skin. There are no dilated veins, sinus, fistula. No visible peristalsis or pulsation noted. Hernial orifices are no visible coughing pulse present. External genitalia appear normal. Inspection of the back and spine unremarkable. Renal angle, no visible fullness noted. On palpation of the abdomen, on superficial palpation, no local rise in temperature or tenderness noted. A firm, non-tender globular lump of size approximately 5 cross 4 centimeter, palpable below the right costal margin, smooth surface, moves on respiration, moving side to side, of which upper margin could not be palpated. Liver and spleen not palpable, no other lump palpable. Hernial orifices are intact, external genitalia normal, renal angle no tenderness, no parasomnal tenderness noted, left to supraclavicle lymph node not palpable. Percussion, dull note over the lump, rest of the abdomen tympanic note, no shifting dullness present. On auscultation, bowel sounds were present. Perineal examination, perineal skin was normal, no fissure, fistula, hemorrhoids, sinus noted. On digital rectal examination, anal tone normal, no growth or deposits palpated, mucosa freely mobile, finger fecal stain present, pale stools, no blood stain present, prostate not enlarged. So coming to the summary, a gentleman aged 46 years,
Monisha,
chronic smoker and
what do you mean by hernial orifices? You said you look for hernial orifices, normal. Can you see the hernial orifices?
No, sir.
Then
No, she has
The
only put the
landmark.
cough impulse. No. What? See the inspection. You have put only the cough impulse, sir. No visible cough impulse present in the hernial orifice. I think that is absolutely acceptable.
hernial sites you can mention. Instead of saying hernial orifices, hernial sites you can say. Okay.
Yes, sir.
Hernial.
Similarly, globular mass, don't mention globular mass.
Okay, sir.
It's smooth surface.
Yours.
What is the consistency? On
The
tender,
forms.
firm in consistency.
Can you go to the inspection slide? No?
Yes, sir.
Previous page. Yeah. Next. Tell me, please, what dilated veins you look for, which sinus you look for, and which fistula you look for.
Sir, dilated veins around umbilicus, sir.
Dilated veins on the umbilicus you looked for. For what?
So anywhere over the abdomen skin, sir, I looked.
Be specific. What are the things? What are the dilated veins you look for?
So in case of portal hypertension, periumbilical veins will be dilated, sir.
Periumbilical veins will be dilated. Suppose with the lateral thoracic veins or lateral side there is a veins are dilated. You are not looked for that.
So in IVC obstruction, also veins will be dilated, sir. Below the umbilicus.
Suppose if it's a common iliac vein obstruction and IVC obstruction, how would you know? This dilated
IVC
veins
obstruction.
alone can give you able to give you a lot of findings.
Yes, sir.
So we must know which are the dilated veins you will look for. Which sinus you look for in the abdomen. This is a routine statement we are making. No dilated veins, no sinus, no fistula. In this case, with related to your finding cases, anything which you are going to look for the sinus, which fistula, as far as possible, try to say what you have done. What is the investigation? Yes, that will be always better one.
Yes, sir.
So why do you look for supraclavicular nodes?
So supraclavicular lymph node will be enlarged in gastrointestinal malignancies, sir. Abdominal pathologies.
Why do you look for?
Sir, since I'm having malignancy diagnosis, sir, I looked for the lymph node enlargement, sir.
Where do you look for?
So where, sir? So left supraclavicular fossa, sir.
Left. What is the boundary of supraclavicular fossa?
So between sternal and the clavicular head of the sternocleidomastoid muscles.
So not the level 5 node is not a supraclavicular node.
Is a 4B and 5.
Okay, you are going to look on the 5 also. So here you are going to specifically look for the virtuous node.
Virtuous node, yes, sir.
Only in the 4B node. Okay, it's not the level
Yes,
5 nodes will not be involved. If the level 5 node involvement, you are not going to say it is a virtuous node. And can you trace and why for pancreatic carcinoma you are going to look at the virtuous node? How the tumor cell will reach there?
So we are thoracic duct, sir.
Thoracic duct is thorax, no? Your mass is in the abdomen. You are suspecting the problem in the pancreas is in the abdomen.
So peripancreatic nodes.
Okay. Trace it and how it goes to the supraclavicular node.
So peripancreatic or retropancreatic nodes, sir. Then paraaortic nodes.
Paraaortic node is below. Okay, paraaortic nodes. So what
Station
is the
40.
Lymph sac in the abdomen? From where the thoracic duct starts? Okay, it goes to cisterna chyli. From there, can you trace the thoracic duct from how it goes? So through which opening from passes through? Along with what it goes?
Sir, aorta, sir.
Okay. What is the pathway, from which is on the medial, lateral, and where it crosses? Where it opens?
Sir, at the junction of left subclavian vein and the interjugular vein, sir.
So how do you get to supraclavicular node?
So when tumor cells obstruct thoracic duct, sir, regurgitation of the
Okay.
tumor cells into Virchow's node, sir.
Okay. The supraclavicular nodes will also drain there. So you get a, so when it is thoracic duct is obstructed, it is not a retrograde flow. So you are rightly said the word regurgitation to the supraclavicular node. So you are look for that. It is not there, no?
No, sir.
Okay. Why do you look for renal angle? What is renal angle?
So the angle formed by the 12th rib and the lateral border of erector spinae muscles.
Okay. What is there normally present?
Sir, no visible fullness, sir. It is resonance.
No, what is there
Sorry,
normally?
no tender.
There?
So kidney, sir.
Kidney. Normally. Suppose it is enlarged. In a renal mass, normally it will be empty or not.
So there
What is
will
the
not be any
normal-
mass palpable usually.
What is the normal percussion in the renal angle? Is it, when you are percussing, is it going to be dull or? So you are not
Sir.
done. You are not. Every case when you are seeing clinically, go and check for a renal angle, percuss it. What is normal? Then only you will be able to make it out. There is an abnormality is there. When there is a kidney is enlarged, when there is any other thing is there, that is what you are going to see the ones. Otherwise, don't just saying a renal angle, no visible fullness is not going to be of importance, because what is
Okay, sir.
normally there in the renal angle and what is you are going to see is important. So what do you expect
Okay.
in the inspection of back and spine means what?
Sir, any visible deformity, sir?
What deformity you can get?
So, because of any metastasis, sir.
Metastasis? What kind of deformity you will get?
So
You will get a swelling? Will you get a swelling?
Step deformity.
Step deformity. Okay.
I'm not sure, sir.
Okay. Which part of the secondaries will go? To the body or a transverse process? Which part of the, okay, go read. It will be transverse process, not in the midline. So you will not get a swelling unless it is a tuberculosis where you are going to get a pericolic collection. I mean, spinal collection. You will not get it. It's only the dimple or the, as you said, the stepping pattern will be a little bit
Yes, sir.
diffused. Okay. And I am of the opinion of when a PG is examining, if you are you are feeling a gallbladder, no? What you are
Yes,
saying is that, so you can obviously say when you are saying the liver is not palpable. Similarly, you can say that I am able to feel the gallbladder, which is there is no need to beating around the bush. As the postgraduate final year, when you are presenting, you can differentiate what is the gallbladder.
Okay, sir.
Similar to examination of neck nodes, don't say start with swelling, like a swelling examination. Straight away go for saying lymph node. It's a lymph node of size. Like that you can, here also you have to say it's a gallbladder. Okay, because
Yes, sir.
you have to towards the major diagnosis. Okay, right.
Yes, sir.
Only doubt is it's moved side to side. I'm not sure it is going to be firm swelling. Upper border is not palpable. That too only 5 cross 4 centimeter. I don't think it will move freely side to side. Okay. Yes.
Sir has already informed you. Don't use the word globular.
Yes, sir.
And also
Yes.
the 5 into 4 cannot be globule. The globule swelling will always have only one diameter.
Okay, sir.
What do you look in the external genitalia for this?
Sir, any testicular swelling, sir?
For what? No, what you are testicular swelling? how you are going to relate to your history?
Sir, a patient having testicular malignancy can have parietic lymph node enlargement, sir. Lymph
No,
nodal
you never had.
enlargements.
No, you have finished your palpation. You have finished your palpation. You are not
Yes, sir.
saying
Yes,
there
sir.
is parietic node. No, then now you are going to see now whatever you are seeing only epigastric region. There is a fullness, and that is sorry. The gallbladder is palpable. That is all you are finding, and that
Sir,
angle.
yes. Sir, to complete abdomen examination, I examined all those things. Sir, should I really mention it, sir, or not, sir?
Absolutely no. There is nothing called completion sake examination.
Okay, sir.
In the postgraduate examination, there is nothing called completion sake. There is reason. You are suspecting a tuberculosis. I mean, there's 25 years alcoholic, a 25 years smoker. You can definitely have symptoms of cirrhosis. And testicular examination, atrophy, so all are features which related to the cirrhosis.
Okay,
So
sir.
in our history, there is some relationship. Not that for the completion sake, we are not going to do that. Whatever test you are going to see, it is only for seeing something. Even hernial orifice, you are going to see if there is an ascites it can produce or it can be associated with that patient.
Okay, sir.
Munisha, anatomically it's gallbladder, no?
Sorry, sir.
Anatomically it is gallbladder mass.
Yes, sir.
Whether it is a gallbladder mass, distended gallbladder, or just gallbladder, palpable gallbladder.
So this is distended gallbladder, sir.
How can you say it's a distended gallbladder? Usually,
Sir,
what
it
will
is
be the
firm.
finding? Distended gallbladder will be seen more than palpable.
Yes, sir. Better seen. Yes, sir.
Better seen than palpable. Number one.
Yes,
It
sir.
moves with the respiration. Okay.
Yes, sir.
Also, size criteria. It won't be of 5 centimeter size. It will be more than, even it can come up to right lumbar region, like that. Huge distended gallbladder. Okay.
Okay, sir.
If it is going to be gallbladder mass, what is the surface? Surface
Sir,
will be
hard nodular will.
nodular surface or irregular surface, right?
Yes, sir.
If it is smooth surface with a firm mass, gallbladder, what do you think of? What is the condition called?
Sir,
Firm or
curvaceous
hard
lines.
gallbladder, smooth surface. What type of gallbladder it is? What do you call it as?
Mucosal, sir.
Porcelain?
Porcelain gallbladder.
Porcelain gallbladder. What is the significance of porcelain gallbladder?
Sir, it has 25% risk of gallbladder malignancy, sir.
Malignancy. One more thing related to malignancy, related to gallbladder. Anything, any space occupying lesion that causes malignancy? Any other thing?
For gallbladder carcinoma, sir.
Polyps, okay.
Polyps,
Large
yes, sir.
polyps also. Polyps
Yes, sir.
and porcelain gallbladder. So you have to clinically suspect. You have to differentiate also. Distended gallbladder, gallbladder mass, or thick-walled or porcelain gallbladder. You have to
Okay, sir.
rule out by surface, like that. Surface examination, nodularity, size, movement with respiration, occupancy, everything. Okay.
Okay, sir.
Go to the yes. Next slide. Okay, percussion, the significance is you have to look for liver span, whether it is liver is enlarged or number one, or the mass you said upper border is not palpable, whether it is continuous with the
Continuous with the liver dullness.
liver dullness or
Yes, sir.
not. Okay, go to the
Okay,
next
sir.
slide.
Can you tell me how did you do the liver dullness? In the liver span, how did you measure? Because you have
Sir,
not
in the
mentioned the liver span here.
Sir, since I put not palpable, I didn't put. Sir, start
No,
in the midline.
even then we are worried micronodular also. We are not only worried about the macronodular. A cirrhotic patient can have a shrunken liver. That is also significant, no?
Yes, sir.
So
Yes,
you
sir.
must examine for a liver span to see whether the liver is there. And what is
Okay, sir.
visceraptosis? What is visceraptosis? A normal liver can be palpable.
Hydrohepatosis, sir.
Hydrohepatosis is a little different. At hydrohepatosis, you
Okay,
can
sir.
get the nutritional deficiency. Even
Okay,
ordinary
sir.
visceraptosis, the liver can be pushed down and you can palpable. So we are not worried about whether it is a palpable or not only. What is the liver span? And
Liver
how do you
span.
measure the liver span?
Sir, in the midclavicular line, sir, starting from second intercostal space, I'll start percussing in the intercostal space. So the space where the point where I feeling the dullness, sir, I will note it down, sir.
Mm.
Then we'll percuss
here-
down. They'll trace the liver dullness, sir.
No, here in this case, if you are going same in the midclavicular line, your dullness will continue with the gallbladder.
Yes,
You will
sir.
not be able
Sir,
to differentiate whether it is the liver.
Yes,
Are
sir.
you going
Since
to
this patient is
what is the
having mass,
normal?
I can use anterior axillary line also.
No, ideally it is from midclavicular line, you go to the anterior axillary line. It's a oblique. When you are going vertically down, your liver span will be always measure less. And the ideal method is going towards the anterior axillary line, and you are going to see further. And you have said no shifting dullness. That is it. You are done for seeing for any ascitic fluid. So is there
Yes,
any
sir.
minimal fluid?
No, sir.
Okay. Why you are not done a minimal fluid then? How do you measure the minimal fluid ascites?
Sir, a niche's position, sir, but which is not preferred nowadays, sir.
You can put a left lateral position.
Left lateral push. Okay, sir.
But you are clinically saying no shift in dullness. That is not giving you the full diagnosis whether there is any minimal collection is there or not. Okay.
No free fluid.
No,
Yeah, to
you have
say no free fluid. Yeah.
when the flanks are full only, you have to look for shifting dullness.
Okay, sir.
Otherwise, you cannot do it. Okay.
Yeah, okay, sir.
Next slide. Next.
So you have said the fecal stain pale stool. What is pale stool?
Sir, it will. It's a clay colored stool, sir. Pale stools.
Clay color. What is the color of the clay? Have you seen a clay?
Yes, sir.
What is the color of the clay?
Sir, it is a bit grayish, sir.
With
Grayish, sir. Grayish. Gray.
gray clay you are seeing. Okay. So that the color?
No, sir. No, sir.
No, sir. Then what is that you have mentioned as the pale stool? Unless you know what is the color of the previous stool for him, and you will
Yes,
not be
sir.
able to come to a categorical statement that it is a pale color stool. That is only from the existing stool, the color is reduced. It is becoming a dull or the pale.
Okay, sir.
So whether you can make it very, very difficult, I'm not sure whether you'll be able to comment on that.
Okay, sir.
In the what is Thompson sign they have put in the chat box we are getting.
Thomas
When
sign,
you
sir.
get
Silver stool.
Thomas sign, silver stool.
Silver paint stool, yes.
The prostate is not enlarged. What do you mean by that?
So prostatomegaly is not there, sir.
Is the normal prostate is palpable or not?
Yes, sir. One finger breadth, sir.
Normal prostate is palpable. Then how do you say there is no prostate is enlarged? What is the criteria to say that this prostate is not enlarged?
So finger breadth criteria, sir.
Finger breadth. Okay. If it's one finger you are palpable, it is not enlarged. Two finger is palpable. So can you get a malignancy in a prostate with a non-palpable prostate, or prostate is just palpable? Can it be a malignant? How will you differentiate whether
Yes.
it's a malignant or benign? In a per-rectal examination, is there is any way you can say this could be a most probably a benign tumor, it could be a malignant tumor?
So consistency, sir.
It will be hard, sometimes firm. Both will be almost same. Any
I'm not
groove
sure,
you
sir.
will feel? Any obliteration of any groove?
Yes, sir. I forgot,
Okay,
sir.
don't just write prostate not enlarged. Whatever you say, it is better you can go and say it is a normal. You say not enlarged, it is a very significant one. The
Okay, sir.
normal prostate can be also palpable.
Yes, sir.
Okay. Which tone you are saying? Anal tone is normal. Which tone you are mentioning?
Both resting and contracting,
Resting and squeezing.
squeezing.
Okay. What is the resting tone? What is squeezing tone?
So resting tone because of the internal sphincter, sir.
Internal
And when I
anal.
ask the patient to squeeze,
So they are
then
normal. And you are
yes.
specifically writing no growth or deposit palpated. What is the difference between growth or deposit?
Sir, I look for any growth in the rectal, sir, or the deposits in the vesicorectal pouch.
So how will you differentiate? Suppose there is a vesicolectal pouch, there is a deposit. How will you differentiate it from rectal carcinoma?
So it will be felt as indurated deposits, sir,
Both carcinoma
over
will be
which I
also
can.
felt as a carcinoma will also felt like an induration.
Sir, rectal mucosa can be mobile over that.
Very good. Mucosa will be indent. How do you differentiate it from prostate?
Sorry, sir,
There is
prostate.
a mass. You are seeing for a prostate, and also you are seeing for a vesicle, the deposit. Suppose the deposit is palpable. How will you differentiate? It is not a prostate. It is only a deposit. It is only the where you are going to feel, which is lower.
More cranially will be Bloomer shelf, sir. More caudally will be prostate.
Okay. So mucosa is freely mobile. That's fine. Go ahead.
Sir, a gentleman aged 46 years, chronic smoker and alcoholic, presented with painless progressive jaundice and passage of high-colored urine and pale stools for 1 month, with itching all over the body for 20 days, with loss of appetite and unintentional significant loss of weight. On examination, the patient is ectric with scratch marks noted all over the body, with palpable gallbladder, no free fluid and no palpable left supraocular lymph node is there, sir. So my provisional diagnosis would be obstructive jaundice secondary to carcinoma head of pancreas, sir. Differential diagnosis were or distal cholangiocarcinoma, periampullary carcinoma, and carcinoma gallbladder.
So what points are in favor of your carcinoma head of the pancreas?
The patient
First of all, your jaundice is a painless jaundice.
Is a painless progressive jaundice.
So is it a common feature of a jaundice you are going to get in a pancreas?
So in advanced cases of carcinoma head pancreas, it will be essentially pain, sir.
No, always carcinoma head only advanced case can produce a jaundice. The early case of carcinoma head can never produce a obstructive jaundice. So usually when we think painless jaundice and painful jaundice, painless jaundice, what is the common cause? Painless jaundice, what is the common cause?
Painless jaundice, periampullary carcinoma, distal, sir. And in early stage of carcinoma head of pancreas. So painful jaundice will be carcinoma gallbladder, hilar cholangiocarcinoma, and advanced cases of carcinoma head of pancreas.
So what is the cause for pain in the pancreas?
So involvement of retroperitoneal nerves, sir. Or if it is associated with the chronic pancreatitis, increased intraductal pressure also can cause pain.
So it cannot be advanced case of carcinoma.
Yes,
even
sir.
an early case of carcinoma prostate can be painful because it is surrounded by the capsule, the nerves, sympathetic nerves can stretch and it can produce a pain. So the pain in the carcinoma head is not an advanced feature.
Okay, sir.
And what else you made it to think? Because clinically, what is the evidence to say it is a head of the pancreas? Your patient has no pain, no diabetes, no vomiting. No, what made you to think?
Sir, yes, sir. Some chronic smoker and alcoholic male, sir. Presenting with painless progressive jaundice, I think. So most common symptom will be anorexia, asthenia only, sir.
Okay.
Followed by abdominal pain, followed by jaundice, sir. But my patient is not having abdominal pain, sir.
Okay. Periambulary carcinoma, is it include head of the pancreas?
So if it is 2 centimeter from ampulla, sir.
Okay. That is also a part of it. So to be on the safer side. So because periambulary carcinoma is a wide range you are going to make.
Yes, sir.
No, you are going to say early part of the head of the pancreas within 2 centimeters, ampulla, all that things. So clinically, provisionally, you can put that as a first choice.
Periambulary
That is my
carcinoma.
priority. But to say head of the pancreas, to say as a first and foremost, then either you are feeling a mass or you are feeling a lot of features in favor of pancreatic carcinoma, you can make that as a first choice. It can be anything, and we are going to make on our investigations.
Okay, sir.
Munisha, how you can say carcinoma gallbladder will cause jaundice? Will it cause jaundice? Carcinoma
Yes, sir.
gallbladder?
Yes,
How?
sir. Sir, carcinoma gallbladder infiltrating common bile ducts or common hepatic duct, or if it is a large mass causing compression effect of CBD also it can cause, sir. Lymph nodal masses at porta hepatis can cause obstructive jaundice, sir. Multiple liver metastasis can cause obstructive jaundice, or even if a single metastasis in the caudate lobe can cause, or if it is associated with dual malignancy, it can cause jaundice, sir. Or associated concomitant CBD stones also can cause jaundice, sir.
We are not thinking of stone disease causing obstructive jaundice here in this patient.
So why I am not thinking, sir?
Yeah.
Yes. One is you are painless, no? That is one reason.
Is a painless or associated with loss of appetite, loss of weight, it's a
No,
progressive.
forget that. If there is a painful, even if there is a painful.
Yes, sir.
Why not you are thinking in terms of stone?
So one thing is painless jaundice, sir, and it's a progressive jaundice, sir. Associated with loss of appetite, loss of weight, sir.
Progressive, there is again two words in the progressive. Progressive and persisting jaundice, and progressive and deepening jaundice. In a given chronic active hepatitis, or that you can get a jaundice which will be persistently progressive, slowly progressive. There will be progressive deepening of the jaundice. Is there a progressive deepening of the jaundice in your case? How do you say progressive deepening of the jaundice clinically?
So change in color of the jaundice, sir, to
What was the
greenish.
color change? Greenish?
So from lemon yellow to orange to green, deep green.
Then? So what is that
So
color due
yellow,
to?
brown.
The green is due to what? Brown is due to what?
So brown is due to biliverdin, sir.
Biliverdin and bilirubin. So which one will first occur?
Yellowish brown, sir.
So the biliverdin will come, then you have a bilirubin will increase, then later when you are having a progressive deepening, again it will be converted to the biliverdin. That's it. So in your case, what is the state? Is it a deepening of the jaundice is there?
No, sir.
No. So it is almost a static jaundice, progressive or static jaundice.
Yes. So stones will be having intermittent pain, intermittent jaundice, intermittent fevers.
Yes, I said that leaving aside the pain. That is what. How do you explain? All other things can be explained because the patient is 25 years alcoholic and smoker. Your loss of appetite, weight loss, everything can be explained by that. How will you classify obstructive jaundice?
Sir, it can be complete obstruction, sir. Segmental obstruction, intermittent obstruction, sir. Or a chronic partial obstruction, sir.
So what is this jaundice you are getting?
So it's complete progressive jaundice, sir.
Okay, how you are going to proceed?
Sir, I would like to get an ultrasound abdomen, sir.
For what?
Sir, to look for origin of the lesion, sir, and to look for IHPRD, liver status, any lymph nodal mass, any free fluid, sir.
When will you say IHPRD?
Sir, if it is more than 4 mm in the central biliary radicals, and if it is more than 2 mm in the peripheral radicals, sir.
Intrahepatic CBD, when will you say it is enlarged?
So it depends on the age, sir. Till 60 years, it
You
is
are
6
asking about
mm.
your patient only.
Sir, if it is more than 6 mm, sir.
Suppose you develop an obstructive jaundice, and how much time it takes for the intrahepatic biliary radical to dilate? So today you are seeing that if I am checking the stone is obstructing, will today there will be intrahepatic biliary radical will be obstructed enlarged?
No, sir.
It will take time, minimum 2 weeks time for that to see that. So you are you are going to see the HPR dilatation. Anything else you are going to see with ultrasonogram?
Yes, sir. Any lesion, sir. Organ of the lesion. And CBD diameter, sir. IHBRD. So liver, any metastatic lesion, sir. Free fluid, sir. Lymph nodal mass. Like, see, sir.
What next?
Using Doppler, even portal vein thrombosis also can sometimes be any luminal attenuation, compression, portal vein, so splenomegaly, if it is there.
Very good. What else?
So next, blood investigation, sir.
Can anything other than this routine ultrasound? Any advance in the ultrasound you can do? What is elastography?
Yes, sir, ultrasound. So elastography denotes this tissue stiffness, sir. If it is more,
So
more suggestive of malignant disease, sir.
So you can do ultrasound. What is the contrast enhanced ultrasonography?
So contrast enhanced ultrasound uses microbubbles, sir. In first generation, contrast enhanced it uses air microbubbles, sir. In second generation, they use perfluorocarbon nitrogen microbubbles, sir.
Okay, very good. So ultrasound, you can include all these things. You must say. So you are saying
Yes,
the
sir.
routine ultrasound. Then you are going to can use an advanced ultrasound for contrast enhanced or elastography, whatever investigation you are going to. Even is there any role of
Fibros can also, sir.
endo ultrasonography?
Yes, sir. Endo ultrasound is for staging of the disease, sir.
Okay.
If the lesion is too small in the CT scan, if it is so not equivocal in the ERCP, then we can go for EUS, sir.
So any role now after ultrasonograph, what else you want to do?
So blood investigation, sir.
Straight away. Okay. You don't want to CT scan or do CT scan?
So before CT scan, I would like to check the renal functions, sir, creatinine and everything, sir.
So if the creatinine value is high, what do you do?
Sir, I would like to treat the acute kidney injury, sir. So I would like to correct it, sir, by hydration.
Hydration. So why you are afraid to do a CT?
Sir, because there is a chance of hepatorenal syndrome, sir, in obstructive jaundice patient. Patient might land up in acute kidney injury, sir.
Which is going to cause the is a CT scan or contrast?
Contrast, sir.
So if there is any advance in the contrast you are going to use in the CT? Can you use a non-iodinized contrast? Or can you do a CT without contrast?
Yes, sir, but to look for resectability criteria and vascular involvement, CCT abdomen will be better, sir. Contrast enhanced will be better, sir.
Okay. So either you can check the creatinine level, you can reduce it, hydration, or the drugs you can use, or you can still go with a non-iodinized contrast was there, or if it is possible, you can do the non-contrast also. So if that is, so what you are going to specially look for in the contrast, I mean in a CT, other than what you are not learned in the ultrasonogram?
Sir, the origin of the lesion, size, and its.
No, your ultrasound has also said, no? What is the advantage of doing a CT?
Sir, invasion of surrounding structures, sir, vascular involvement, basically resectability criteria, sir. Resectability
Invasion or you are going to see invasion or infiltration?
So infiltration into surrounding structures and vascular invasion, sir.
What is the difference between invasion? What is the difference between infiltration?
I'm not sure, sir.
Oh, invasion is only a horizontal phenomena. It is not something which, but infiltration is from the tumor. It is vertically. It is growing into that. CT cannot differentiate the infiltration unless whatever you can say is there is a tissue plane is there or not. Tissue plane can be lost in various reasons. So infiltration can be confirmed only when you are going to do a biopsy or when you are going to do the specimen examination. Not is very simple. The invasion along the vessels, along the tumor, you can see there is an invasion is there. That your CT can pick up the invasion, not the invasion. So whether it is encased or encased invasion is there, where perineural invasion is there, that the MRI can pick up, but not the infiltration cannot pick up.
Yes. So then, any distant metastasis also?
In the nodes you are examining, is there any difference in the nodes examining by ultrasound and CT?
So in ultrasound, the nodes will be taller than wider, sir. Loss of fatty hilum.
No. Both can pick up. Ultrasound can pick up.
Yes, sir.
What CT will be more than ultrasound?
Sensitive.
It can pick up something. Why it is sensitive more? The ultrasound cannot pick up isoechogenic nodes.
Okay, sir.
So it is only going to be differentiated with the echogenicity. When there is a node and the tissues are going to be the isoechogenic, you will not be able to get that. So that isoechogenic nodes also can be picked up by the CT scan. So you need a CT for picking up isoechogenic, looking for invasions, things, anything else. CT advantage. You can have a protocol CT.
Yes, a pancreatic protocol. Yes.
Okay, that will be able to give you that. So what is the protocol CT?
So in pancreatic protocol, there are 3 phases, sir. So basically, we will give 1.5 ml per kg contrast, sir, at 3 to 4 ml per second, sir. There will be 3 phases taken, sir. Early arterial phase and pancreatic parenchyma phase and portal venous phase, sir. So which will be 15 to 20 seconds and 35 to 40 seconds, 60 to 50 seconds, respectively. So in early arterial phases, neuroendocrine lesions will be picked up, sir. And in parenchyma phase, hypoenhancing lesions, which will be pancreatic ductal adenocarcinoma. And in portal venous phase, we can pick up hepatic metastasis, sir. Or even portal vein thrombosis, we can pick up, sir.
You will only do a pancreatic protocol. You will not do a liver protocol? You want to do or you don't want to do?
No, sir.
Because you feel that it is in the... So, is there any role of MRI?
Yes, sir. Sir, if my ultrasound is showing upper CVD cutoffs or any stricture, I would like to go for a MRI, sir, to look for biliary system, sir. Any intraluminal pathologies.
So you are done your CT or MRI?
Yes, sir. CT done, sir.
Okay. What is the finding?
Sir, there's abrupt tapering seen at the...
You can... Okay, go ahead.
Sir, liver and GP were normal, sir. So in CBD, abrupt tapering seen at the level of distal CBD with the ill-defined soft tissue thickening causing its abrupt cutoff, sir. Likely neoplastic, sir, they have been.
So in this case needs an MRI?
No, sir.
So you are not interested in MRCP or MRI findings?
No, sir.
It can be a stricture also, tapering. Can be a benign stricture.
So abrupt cutoff.
Abrupt cutoff. Something is obstructing, no? That is why it's abruptly cut off. Okay. But ideally, angiogram will be also needed for this case to rule out other features. So you put that LFT values, no? Good.
Yes, sir.
Suppose your patient, you wanted to do surgery, your patient albumin is low. only albumin is only 2.2. So what you will do?
Sir, I would like to optimize this by high protein diet.
So what is the source of albumin in the body?
Sir, liver.
Liver. Is it endogenously synthesized or exogenously you can supply?
So exogenous also we can supply, but its half-life
That
is
will
low.
only not off life. It will only help in your oncotic pressure. It will not be
Okay,
at the serum albumin level. It will not be raised by that unless you are going to rectify the reticular endothelial system and the rest to the liver, and the liver has to recreate. So the tons of albumin you are going exogenously, it is only going to help the pressure of the oncotic pressure of the individual, not the
yes, sir.
albumin will not be there.
Yes, sir. Yes, sir.
So, Saravanan sir, please ask.
Dr. Monisha, any tumor markers would you like to do it? Anything?
Sir, yes, sir. CA 99.9, sir.
Have you done
CA.
it?
Yes, sir.
Why you are only concentrating on CA 199? Any other thing?
So
Any other tumor
CA.
marker? CA,
Yes, sir.
then?
CA.
Because you
CA
have
1.
said pancreatic malignancy also, right?
Yes, sir.
Suspicion of pancreatic initially.
Yes, sir.
Okay. You have to do all the tumor markers. Okay.
Yes, sir.
Sometimes they may be associated with mixed lesions also.
Yes, sir.
What is the role of ERCP in this patient? Any role of ERCP in this patient?
Sir, yes, sir. Since CT is showing stricture, sir.
Ah.
So if we have a doubt of benign versus malignant, we can go for ERCP breast cytology, sir.
ERCP along with the
Cytology, breast cytology.
breast cytology. Any other
Yes,
thing?
a stenting because bilirubin is 32, so we can go for
Ultrasound.
stenting.
Apart from endo ultrasound, any other ultrasound you like to do in strictures? Even in the bile duct, you can pass ultrasound. Okay, that to go to a nearby stricture area and you can do further study. That also you can do. Here the bilirubin level is 32 milligrams. Okay.
Yes, sir. Yes, sir.
Any good thing you consider this level of bilirubin for
So
anything?
yes, so usually it is said 15 to 20, sir.
How will
So
you bring out?
considering this,
How will you bring out?
bring down this bilirubin, sir. So we can go
Suppose
for
you want to
ERCP
do
stenting, sir.
one is ERCP stenting.
So if it is failed, then radiologically we can go for percutaneous PTBD, sir.
Okay. So considering this to be malignant stricture and benign strictures, what are the options available? Benign strictures, what will do?
So
You're
we can
doing
go for
this bile cytology, everything, no malignant cells, and your tumor markers also normal.
so then I will go to hepaticojejunostomy, sir.
Hepaticojejunostomy, very good. Where will you do? Hepaticojejunostomy or choledochojejunostomy or cholecystojejunostomy?
So in benign
Which
cases we can go for
where is the
cholecystogejunostomy also.
anastomosis, exact site of anastomosis for hepaticojejunostomy? What
So
is
if
the
it is
exact
for
site? Yes.
so if it is for malignant cases, it is just below the
No, benign
confluence,
case,
sir.
benign case, benign case.
Benign case.
Hepaticojejunostomy, right? Benign case, you are going for planning for hepaticojejunostomy. What is the level of anastomosis? The biliary tree.
So we can do choledochojejunostomy, sir, for benign cases.
Choledochojejunostomy can be done. Hepaticojejunostomy, if you choose, where is the exact site of anastomosis? What a technique called? Parachute technique, okay? The confluence you have to anastomosis is called hepaticojejunostomy,
Okay, sir.
right?
Okay, sir.
That is for benign strictures you can go for, or palliative stenting if it is possible. If it is
Yes.
malleable, that obstruction is malleable, you can go for stenting also, right?
Yes, sir.
Suppose if I want to do ERCP as well as MRCP, which one will you do first?
Sir, MRCP, sir.
Why?
Sir, it is a diagnostic modality, sir.
Both are diagnostic only. Okay. Which one will you choose?
ERCP associated with the complications, sir.
Okay, that is one reason. Any other reason? Suppose if you do ERCP first, everything will collapse, by biliary tract, all the dilated vessels, tract
Radicals,
will
yes,
go.
sir. Yes, sir.
That's why if you do combine both, first you have to go for MRCP.
Yes, sir.
Because it's self-contrast. Bile is a self-contrast. Suppose if
Yes,
you
sir.
drain out, we cannot go for further study, MRCP. Okay.
Yes, sir. Yes, sir.
Suppose if it is malignant stricture, what will you do? Here, there is no mention about smooth tapering or abrupt tapering.
So they have mentioned abrupt tapering, sir.
Abrupt tapering.
Yes,
The
sir.
smooth tapering you can consider. What do you think of? Malignancy, mostly malignancy. Abrupt tapering, strictures, right? Benign strictures and malignant strictures. In periambular carcinoma, what type of tapering will be there? Periambular carcinoma.
Double duct sign, sir.
A double duct sign will be there. In hypertonic duodenography, what are the findings for malignancy? Various malignancies, pancreatic malignancy, periambular malignancy. Hypertonic nowadays not done, but you must know for academic purpose, the theory part. Hypertonic duodenography, what are the signs? Various signs. What is Rostam? What is pad sign? What is inverted tree sign? All these things you must know. Okay.
Yes, sir. So
Okay.
3 sign in periambulary, sir, and
Inverted
tree in.
tree sign. Okay. Inverted tree sign. Okay.
Okay, sir.
For malignant strictures, what will you do?
Sir, will if it is in distal CBD, sir, will proceed with pancreatic duodenectomy, sir.
So you have to look for whether it is a supraduodenal or retroduodenal or intraduodenal lesion.
Yes, sir.
If it is supraduodenal, you can palliative, you can go for palliative, choledochogestomy or hepaticogestomy, palliative measures, or Whipple's procedure you have to go think of. Okay.
Yes, sir.
Whipple's, what are the various modifications? What are the ideal Whipple?
Sir, pylorus preserving pancreatic duodenectomy is there, sir.
Why it is chosen?
Sir, to decrease the instance of delayed gastric emptying, sir.
Okay. What is the ideal anastomosis? Whether
Sir, there is no
gastropancreatic-
supporting evidence for ideal anastomosis, sir. It's depending on the surgeon choice, sir, and based on the pancreatic texture and pancreatic duct diameter also, sir. If it is soft and non-dilated duct, we can go for pancreatic jejunostomy, sir. But
It's based on the technicality and
if
expertise
the
of the
surgeon,
surgeon.
yes, sir.
Okay.
Yes, sir.
The available tissues, pancreatic tissue, and nearby, whether it is a stone is nearby, if the posterior stomach is nearby, we can go for pancreatic gastrostomy also. Okay.
Yes, sir.
Good
It is going
mention this.
Yes, sir.
Go ahead, sir. Go ahead. Go ahead, sir.
Please, I carry on. Please.
No, in this investigation that is on the screen, it is only there for a long time. Can you read what are the abnormalities here?
Sir, rise to total bilirubin and rise to direct bilirubin, sir.
So how much
enzymes
is
are normal.
maximum bilirubin maximum can go?
Sir, up to 40, 45, sir.
Why?
Sir,
not
after
100?
that, the intestinal epithelium will start exfoliating, sir.
Okay. The pressure in the blood can cause the compression, and that will be non-functional also. The follicle cannot go on secreting. Is it the SGPT, SGOT is the term which we are using now?
Sir, AST, sir.
Oh. So what is the value of ALP? What is the normal value?
Sir, up to 120, sir.
So here it is raised. What is the why ALP is raised? ALP is secreted from where?
Sir, bile duct epithelium, cholangiocytes and hepatocytes.
So how will you? What are the other sources of alkaline phosphatase?
Sir, from bone, from placenta, sir.
How will you differentiate? It is only from the liver.
Sir, 5-nucleotidase is specific for liver, sir.
Okay. What is this? GGT is increased or?
So increased, sir.
What does it indicate?
Sir, rise to GGT is also specific for obstructive jaundice, sir. And also in alcoholic liver disease, sir. But
it's more in favor of alcoholic.
yes,
not
sir.
In phosphatase. So you have any tumor markers for the liver you have done? Not.
No, sir, not done, sir.
So what is the common tumor marker you are using for the liver carcinoma, hepatocellular carcinoma?
Sir, alpha fetoprotein, sir.
Can you get a liver cell carcinoma without alpha fetoprotein increase?
The fibrolamellar variant, sir.
So how will you, what is the tumor marker you use for fibrolamellar? Neurotensin B.
Okay, sir.
Okay.
I'm not sure, sir.
Okay. So how will you class the classification? It's a staging
Sorry, sir.
or the huge. How will you stage this with the liver function in a patient whenever you are going to do a surgery on the patient?
So staging of liver function test, sir.
Based on liver function test, how will
Yes, sir.
you, which category of the patient they are going to, A, B, C? Child's criteria.
Child book C.
This belongs to, your results belongs to which criteria?
Sorry, sir. I had to calculate.
Okay, you are not here. All other features are normal, no, except your bilirubin level. That is only 1 point there comes. So
Yes, sir.
it looks like it will be still in a child's A.
Okay, sir.
Oh. So what else you look in the child's? What is Raynaud's
Pentad, sir.
pendant?
Sir, it will be containing of pain, jaundice, fever, sir, associated with altered mental sensorium and hypotension, so septic shock, sir.
Why you have put as a PT/INR?
The prothrombin time and INR, sir.
Okay. No, why you are what is INR?
So internationalized normalized values, ratio, sir.
How it is calculated?
Sorry, sir, I'm not sure, sir.
Okay. It is not for a single patient. It's an average. They have a cutoff value. They keep, and from there we are going to see that how much up to what we are when looking at this INR value. What gives you an idea when your bleeding time, clotting time will be normal? Looks like so. There is no need for giving a vitamin K or additionally because the patient is still in a stage of a much better control. So, what you are planning for your case?
Sir, pancreatic sir.
Ripples.
Yes, sir.
So, with the 32 with the bilirubin level, are you planning for any bypass
So
or
before,
any
so before surgery, yes, sir, will optimize the patient, sir. So since the bilirubin is 32, sir, usually it is taken as 15 to 20 cutoff, sir. So I would like to go for biliary drainage, sir.
What is the advantage? What is the
ERCP stent.
disadvantage?
Sir, we can go for ERCP stenting, sir. But it can
What is
cause
the
other
advantage
shunts.
of stent? What is the advantage of stenting and what is the disadvantage of stenting?
Sir, advantage of stenting, rise to bilirubin will cause cardiac dysfunction, sir. That will be issue for the patients during surgery. Post-op management will be difficult, sir.
So what complications?
And renal function and even acute kidney injury also patient can get, sir. So patient will be immunity will be compromised, sir.
By putting a stent?
So disadvantage of stenting will be adhesion, sir. During surgery, there will be a lot of adhesion, sir. And even the studies saying there are increased risk of surgical site infection also associated with the ERCP stenting, sir.
Surgical site infection, and that can also lead to your infection. What is the mechanism of hepatorenal syndrome?
Sir, rise to bilirubin, sir, causing cardiac dysfunction. Sir, LV dysfunction, sir, causing atrial dilatation, producing ANP, sir, that is causing diuresis and natriuresis, sir. So patient will be having decreased volume, sir. Another thing would be, sir, coagulation will be altered, sir. That will cause fibrin deposition at the cortex of the renal cortex, sir, causing necrosis. Other thing will be, sir, endotoxinemia affecting kidneys, sir. That might be due to decreased glucose.
That is also a major problem, endotoxinemia. So on one side we are thinking the bilirubin level is increased, that can cause this problem and produce hepatorenal syndrome. Similarly, when we are going to induce infection, that can also add on to the development of the hepatorenal syndrome. So how will you treat hepatorenal syndrome or prevent?
Sir, hydration of the patient, sir.
One is
And
hydration,
prophylactic antibiotics, sir.
antibiotics. Any drugs that produces relatively vasoconstriction, intrarenal vasoconstriction. So to produce that ischemic changes, you can is the vasodilators. Any particular drug? What is hepatopulmonary syndrome?
So pulmonary dysfunction in the setting of hepatic dysfunction, sir. In the absence of pulmonary disease, primary pulmonary disease.
What are the pulmonary dysfunctions you get? What is hepatopulmonary syndrome? What is hepatopulmonary hypertension? There's a two entities there. Like what we are saying about hepatorenal syndrome. Here one is the hepatopulmonary syndrome. Another is hypertension. One is producing hypoxia. So one complication, patient will go for a hypoxic problem. So that another one you will have the portal hypertension will be also the hypertension of the will be increased. One is the ischemic changes or hypoxic changes. So there is a two entity, separate entity of the like a hepatorenal syndrome. You are having hepatopulmonary.
Okay.
So now, so if when you are doing a surgery, is there any stage that you will say that I will not be able to do this? Proceed with the case.
Sir, initially we'll proceed with diagnostic laparoscopy, sir, in certain indications. Like larger tumors are more than 3 centimeter or tumor markers CA99 point more than 200.
No, there is no contraindication for more than 3 centimeter as a non-operable.
Yes, sir. We will proceed with DL, sir. In DL, if we find any liver metastasis and nodules, peritoneal deposits, or rumental deposits, sir, acetic fluid, which is proven to be malignant on frozen sections, sir. And then, sir, if we proceed with resection, sir, if we couldn't find any plane between SMV and the pancreas, sir, if you couldn't find that tunnel of love, then we'll abandon the resection, sir.
What is tunnel of love?
So the plane between the posterior surface of the pancreatic neck and the SMV, sir.
So why that is a tunnel? It's called tunnel. What keep it as a tunnel? There is no tributaries for the portal vein comes anteriorly. All that comes posteriorly. There is no veins or nothing comes between the portal vein and the parenchyma. Okay. So you can easily put your finger. And
sir,
what you are going to look.
Sir, while test clamping GD also, if you find changes to, if the liver supply is affected, also will abandon the resections.
But what is most important? Which artery involvement? Through the tunnel of love, what you are going to see? SMA. Yes. Why SMA is more significant, not SMV?
Sir, SMV, we can reconstruct, sir.
So artery you can't reconstruct.
We can reconstruct, sir, up to 180 degree.
Okay, then why is we are talking about SMA involvement is the contraindication for surgery? SMA involvement always denotes perineural invasion.
Okay, sir.
So that is the indication of perineural invasion. Perineural invasion is that means there is a limbovascular or the tumor is in an advanced stage. So no point in doing a surgery with a patient with having that is a point why we are particularly saying SMA involvement is very important because that denotes the perineural involvement. SMA involvement is also perineural is also involved.
Okay, sir.
You know the basic steps and what are the complications you get after doing a Whipple's?
So delayed gastric emptying, postoperative pancreatic fistula, sir, post-pancreatic hepatectomy, wound infection.
What are the surrogate markers to look for?
Marker, sir?
Surrogate findings. That is, this patient is going for the pancreatic fistula.
It's a drain amylase, sir. On after postoperative day 3, sir. If it is more than 3 times the upper limit of the normal value of the serum amylase, then we'll consider it as biochemical leak, sir. If it is associated with the clinical events, then we'll rate it as CRPOP of, sir, B and C.
So suppose you have your patient has also a liver involvement, liver secondaries, you say. What is the
Yes.
latest recent concepts?
If it is oligometastasis, we can metastatectomy and proceed.
Even in pancreatic cancer, though we say normally only for a colorectal cancer you do, either due to the hepatectomy or they are even going to the level of doing a liver transplantation. Simultaneously, it can be also attempted. So that is now they are not now become not an absolute contraindication. We can only say all of them with the relative contraindications for that. So on the table you find that is inoperable. I think already Sarah has asked that question. I mean, if it is inoperable, what are the palliative procedures you are going to do?
Sir, triple bypass, sir. Gastrojejunectomy and hepatocejunectomy, sir. And jejunectomy, sir.
So what are the recent advances in the pancreatic carcinoma, inoperable pancreatic carcinoma? What is the role of radiofrequency ablation? What is the role of electrode stimulation?
I'm sorry, sir, I had to study.
You are not okay. Because you are doing extremely well. I think you are one of the best candidates we have seen. You are answering extremely well, and you are very confident of your concepts. So the next level of pancreatic also you can read as recent advances.
Monisha,
Sir,
just one or two
understand?
questions. Yes, sir. One or
Yeah.
two questions, ma. Role
Yes,
of
sir.
biopsy in hepatocellular SOL in liver, considering the malignancy. What is the role of biopsy? Will you do biopsy? You consider hepatocellular carcinoma by tumor marker?
Sir, tumor markers and radiological, we can diagnose hepatocellular
What is the role
carcinoma,
of,
sir, and proceed.
will you do or not?
No, sir.
Biopsy. Biopsy is contraindicated. Okay.
Yes, sir.
If it's a borderline lesion, early lesions, you can go for straight away hepatectomy or hepatic transplantation.
Yes, sir.
Do not do biopsy. That is number one. Sir said some conservative measures like ablations. One more is
Yes.
embolization.
Yes, sir.
What is chemoembolization? What is arterial embolization and portal vein embolization? What is the difference? Arterial chemoembolization is chemotherapy. Can give,
Yes, sir.
or we can occlude the vessel. Whereas portal vein embolization, what is the advantage? What purpose we are doing portal vein embolization? There will be a regrowth, proliferation of the remaining hepatocytes or the other sites
Hepatocytes. Oh, okay,
because
sir.
of the obstruction of the portal vein, blood flow.
Okay, sir.
Okay.
Okay, sir.
So after resection or major resection, that will be beneficial. It is a
Yes, sir.
role of portal vein embolization. You said some diagnostic laparoscopy. If you find node in the abdomen, suppose for hilar node, something else, what is the role of taking biopsy or FNAC from the node? How it helps? Mere enlargement of the node is upstage the disease or not? Or you want to prove the presence of malignant cells to upstage the disease?
Sir, mere enlargement, sir.
Mere enlargement, it may be reactive nodes.
Okay,
So
sir.
to upstage the disease, we need histological proof by taking biopsy or cytology from the node. Okay.
So pertaining to hepatocellular carcinoma, sir, or pancreatic carcinoma, sir?
Hepatocellular. I mean, we are talking about the hepatocellular carcinoma.
Okay, okay, sir. Okay, sir. Okay, sir.
Okay, you've done well. Nicely, very nice.
Thank you, sir.
Monisha,
Yes, sir.
so what's the role of UES and spyglass in case of a periampli and cholangiocarcinoma?
Sir, if the lesion is too small to be characterized in the CT, sir, or if the TRCP couldn't characterize it as benign or malignant stricture, sir.
You know, see,
Yes,
in
sir. US
US,
graded F.
take a biopsy, you can get a better biopsy. In our country, sometimes tuberculosis is the commonest cause of the pancreatic enlargement. So the node, you can very well take the biopsy, you can rule out. We have seen, practically we have seen, tuberculosis is the commonest cause of the nodal enlargement of pancreas in the particular area. And what is the role of spyglass?
Sorry, sir.
In cholangiocarcinoma, how you see the disease? So if the
Sideway.
ERCP, with ERCP you can do a spyglass where you can see the interior of the CBD. So they
Okay, sir.
say they are usually that they are flat lesion. You can take a, you see the disease, you taken biopsy. You said something about the breast cytology, the ERCP, right?
Yes, sir.
In spyglass, you can see the disease and take the biopsy and can prove the disease.
Okay,
Very
sir.
good,
Yes, sir.
very good, very good. You've done very good presentation.
Thank you, sir.
Monisha, I think this is the first time I think single case going for almost 2 hours. So that shows the commitment to you, and I think this is one of the exhaustive discussion of a surgical jaundice in the near past. And I think, would you like to ask any doubts to be clarified with the examiners here? Dr. Monisha?
No, sir. No, sir.
Okay. So good luck. I think you please take note of the areas where you had little challenges in the current recent knowledges, especially the most recent advances, spyglass and other things are exclusive short note questions. And
Okay, sir.
then
Okay, sir.
area where you are little weak, maybe go back to the books. Not a single book may give you the answer, especially the medical gastroenterology textbooks. They give very good basic sciences thing. So Schlesinger or the Schiff's liver disease gives a lot of information. So whenever you find time in the library, you quickly read through the basics of jaundice in those books also. So that
Okay,
gives you a lot of confidence and focus towards better answering.
okay, sir.
So good luck to you. And I think Amit sir has left some time back. So please give our thanks and kind regards to him for permitting
Yes,
you to be part of this. And
yes.
I think there is someone putting surgical jazz classification. Good. Thank you very much. So
Thank you, sir.
faculty, Jalal sir, in spite of his meeting, he could stay back for the
Yeah,
entire
I'm
class.
now rushing it. I have to rush.
Thank you, sir. And Saravanan sir, we informed only in the afternoon. He was very kind enough to agree to this. Saravanan sir, maybe next week you permit one of your boys or girls to present a case, sir.
Sir, one more,
Monisha is
like,
from
one more
Ames
point that,
Rishikesh.
sir. Targeted
Sir.
therapy also they have to read, sir. Targeted therapy for malignant lesions. That also
Okay.
recent advances that the student should be well aware of. And a small advice to the student,
Yes, sir.
Casey Katie should be somewhat careful, sir. She's very
Yes, sir.
educated. That's only the negative point. Otherwise, she's very brilliant and very attentive student, sir. Very nice.
Thank you, sir. Thank you very much, sir.
Thank you very
Thank you,
much, sir.
Dr. Monica. Good luck to you. And
Thank you, sir.
with this,
Yeah, also,
yes, sir.
Saravanan sir has said, please concentrate on clinical finding because we have a very good theoretical finding knowledge. So you are able to put things because what the slide which you have sent earlier and now you are talking because I read before the class. There you are set as a painful jaundice. Now you are changing it to a painless jaundice. That is
No, no,
1
sir.
year.
She did send a revised thing sometime very recent, close to the class time. I forgot to forward it, sir. It's my
No,
mistake.
what I'm
She
saying
did
is
send
that,
it.
that is a clinically that difference should not come.
She is some other patient, sir.
That's a female patient. This is a male patient. Yes.
Yes, sir. She's some other patient, sir.
Okay. You are presenting a
Okay.
different.
Absurd,
So,
sir.
Anyway,
the
very
problem.
good. Anyhow, very good.
Thank you very much, Monisha. Thank you all the faculty. Thank
you
you,
very much.
dear students. And we wish on behalf of the postgraduate clinics and all the faculty here, we warmly wish you the people who are going to take exams in the upcoming month, and good luck to you. Study well and stay focused. Thank you very much. And we call the session a close with the permission of the faculty. Good night, everyone.
Thank you, sir. Good night.
Good night, sir. Good night, sir.